Good afternoon, everyone. It's Mark Gestring. I'm the chair of the AAST Disaster Committee. And it's my privilege to welcome you to this month's virtual grand rounds by the AAST. Today's topic is an extremely important one. I'm going to talk about disaster readiness, specifically pediatric disaster readiness. And I'm pleased to introduce four experts on this topic who really have developed quite the presentation on this topic. Dr. Aaron Jensen, Dr. Chris Newton, Dr. Charles Macias, and Dr. Mary Fallat. Each one has a presentation that they have done together, so that hopefully you will benefit from all four of those. And at the end, we'll have some time for questions. I understand that we will be looking at the Q&A chat section. So if you have a question, please feel free to enter it in the Q&A chat section. Did I do that right, Afia?
Yes.
Okay, then. All right, so I'm going to let each panelist introduce themselves a little bit in terms of their background, but with that, I think we're going to go ahead and get started. Thank you.
Good afternoon, everybody. I'm Aaron Jensen. I'm from the Benioff Children's Hospital at UCSF, and I'm the trauma domain co-lead for the Emsc Innovation and Improvement Center. And happy to be here today. I was asked to introduce the concept of pediatric readiness and talk about why pediatric readiness matters to adult trauma centers and really place this into context of a national disaster preparedness system that integrates kids. So that sounds like a lot to cover, but I can really boil this down to really one thing, which is if you can't take care of an injured kid on a random Tuesday morning, you won't be able to do it during a disaster when resources are constrained, when everybody's stressed out, and the big one hits. So I'd like to talk about pediatric everyday readiness today as a construct for how to maintain preparedness for disaster, particularly for children. A few acknowledgements. I do get some salary support from the government, from HRSA, and what I'm presenting today is my own opinion, not those of the federal government. I come from a pediatric trauma center. This is what we do at pediatric trauma centers. These are two cases that I took care of. One kid who was misidentified and stabbed, had severe injuries, had a supermassive transfusion, got phenomenal care at a pediatric trauma center, went home with no functional deficits. Another child I took care of, this is not him, but a representative pitcher, hit in the head with a baseball, gets rapid care, gets rapid decompression of his epidural, goes home again with no functional deficits. And at pediatric trauma centers, we are by definition prepared to take care of children. We participate in ACS TQIP, we're verified by the college. We have all of the resources. We have all of the specialists with the skills and everything that's necessary to provide high quality pediatric resuscitation and pediatric care. But access to centers like the one that I practice at is pretty limited, particularly where I live. I'm from Northern California. There are 5 pediatric trauma centers in all of Northern California. They're circled here on the map. And just to put the state of California in context with all other states, it's a pretty big place. It's 5 hours to the Oregon border north, and it's 9 hours to the Mexican border south. And the closest pediatric trauma center north in Oregon is actually in the northern half of the state. So there is a vast region of area that just has no coverage of pediatric trauma centers and access to pediatric trauma care where I practice. And a lot of kids live up there, and I take care of a lot of kids that come from this region. So I'd like to ask, what happens to kids when they get injured in this region, which again is a very large area of the state. So this is a child that I took care of, a representative picture. He was vacationing in Northern California with his family, and his dad took him for a ride in the tractor. He was a 3-year-old, 11 kilos. And dad didn't realize, but he fell out of the bucket of the loader, and the tractor ran over him. They called EMS and were instructed to drive 20 minutes down an old country road where they would rendezvous with an ambulance that would then drive them another 20 minutes to the closest trauma center. And this particular trauma center in Northern California is a level 3 trauma center that does have a helipad, but we're now already 40 minutes out from the time of injury by the time they even get to the level 3 trauma center. And this is how kids in rural Northern California get trauma care. These are adult trauma centers in Northern California. I showed pediatric trauma centers before. You'll see here that we have 2 level 2 trauma centers that are along the I-5 going north, but the rest of Northern California is served by level 3 and level 4 trauma centers that primarily take care of adults. This is not just a California problem. This is Mike Nance's work that illustrates access to high quality pediatric trauma care or pediatric trauma centers within 60 minutes by air or by ground. And you can see all that white space on this map is kids that don't have access to a pediatric trauma center. This data has been shown a little bit differently. This is the Governmental Accountability Office. States that are white have very little coverage of pediatric trauma care. States that are a little bit darker are better. You can see up in the Northeast, we have some areas that have 100% coverage of kids, but it's pretty sparsely populated with pediatric trauma care nationally. Only 57% of kids live within 30 miles of a pediatric trauma center. The bottom half of this map, however, leverages any high-level trauma centers. So these are level 1, 2, and 3 adult trauma centers, we like to call them, but they're trauma centers. And if we leverage these centers, 88% of kids in the country now have access to a high-level trauma center. And this is what we are working on at the Emsc Innovation and Improvement Center, focusing on trauma, which is how do we improve initial resuscitative care for kids that may present to non-pediatric centers. They may not get definitive care there. They might get definitive care there. But even if they get initial stabilization and transfer out, how can we improve upon that? How can we optimize that? How can we make sure that these centers are ready to resuscitate kids? I'll ask everybody on the panel today, or on the call, the participants, are the centers in your region ready to resuscitate a child? Do they know how to choose the appropriate endotracheal tube size, chest tubes? Can we give medications, blood, fluids? Do you know how to massively transfuse a child if you need to? Can you rapidly recognize critical TBI, hemorrhagic shock, and transfer out to definitive care if you need to, all while resuscitating while waiting for the aircraft and air transport? So this particular child, who presented to the level 3 trauma center in rural Northern California, arrived in extremis. He was intubated with a 5-0 tube, had a Braslo tape been used. It would have been recognized that a 4-0 tube would have been appropriate for this 11-kilo child. Central venous access was obtained. His initial hematocrit, not his hemoglobin, but his hematocrit was 11, and he already had signs of coagulopathy. Now, this is a critical point. He got 1 adult unit of red cells for hypotension, and his blood pressure responded. So he was deemed to be a responder. I will point out that for an 11-kilo child, a 300 cc unit of blood would be like giving an adult human 6 units of blood. So he was called a responder after getting 6 units of blood, essentially, and sent off to CT. And you can see some cuts of his CT. He has a liver laceration, and I pointed out his stomach and not his stomach on this one, which is his pulverized spleen with a lot of arterial extravasation. And as we can all guess, when he got back from the CT scanner, he became hypotensive and his hypoxemia worsened. He was not stable for transport to the pediatric trauma center, and the adult general surgeon on call for trauma at this hospital agreed to do a splenectomy that day, saved his life. He was transfused to the T per the adult massive transfusion protocol, which was after 4 units of reds, they went 1 to 1 to 1, and that's what he got, which is in accordance with their protocol. But when you look at the actual volumes this child got, which was essentially 2 blood volumes, he got a 7 to 1 to 1 transfusion in terms of ratios when you look at actual volumes. And you'll see the implications of that on the next slide. He was eventually transferred to the pediatric trauma center, where he was cold, hypotensive, and tachycardic, profound acidosis, coagulopathy, and now his hematocrit is 75. His calcium is quite low because their MTP did not include any calcium supplementation for a kid. After all of this was corrected, he actually responded quite well, but did develop a significant lung injury, transfusion-related lung injury, and a prolonged ventilator lean, developed subclottic stenosis. And I'm not criticizing the level 3 trauma center. Again, they saved his life. But some of these complications potentially could have been avoided, and rather than spending 60 days in the hospital, his hospital course probably could have been shortened substantially for a child. But he did go home with no functional deficits intact and a great outcome for our trauma system. So was the adult trauma center that he presented to prepared to care for him on a random Tuesday? Again, this was a day where there was no disaster. All systems were optimal. It was the middle of the day on a Tuesday. And I would argue that at that point, they were not quite ready to take care of a severely injured child. So how do we fill these gaps for early resuscitative care? How do we improve the ability for adults or level 1, level 2, level 3 trauma centers to provide early resuscitative care, to adequately transfuse kids in appropriate ratios, use the appropriate endotracheal tube size, recognize when kids need neuroprotective medications for critical TBI, and more importantly, recognize quickly when they need to be transferred out and activate the air transport system to get them moved. So one way that we can do this, one way that we can prepare is a concept called pediatric readiness. This has been around for over 2 decades now. It's broken down into 6 different domains that are quantifiable. And you can look at these and identify deficiencies and correct these deficiencies. Probably the easiest one to recognize is, do you have appropriate sized equipment and supplies? Do you have all the sizes of the endotracheal tubes? Does your staff have competency in taking care of kids, at least for initial resuscitation? Do you have appropriate policies? Do you have a pediatric weight-based massive transfusion protocol? Do you look at quality improvement? Do you review your pediatric cases and look for quality improvement opportunities? All of these different areas contribute to pediatric readiness. So the Emsc Innovation Improvement Center, our goal and the thing that we're working on is not to create a new pediatric trauma system, but to optimize the current trauma system, and some people might call it the adult trauma system, but to optimize the trauma system to provide high quality care for children within existing resources. This is the overall Emsc Innovation Improvement Center. It focuses on more than trauma. I'm here just to talk about trauma today that really amplifies into disaster preparedness, but you can see all of the various activities. The trauma domain is, I lead this with my co-leads, Mike Dingeldine and Lisa Gray, and we have tremendous programmatic support from many partner organizations. But we took the input of all of these partner organizations and we did a formal Delphi process to identify what are the needs, how can we improve pediatric readiness, how can we improve quality of resuscitation for kids in our national trauma system, and we came up with 4 consensus priorities. The first thing we started working on was getting a pediatric emergency care coordinator in every adult trauma center. We're not there yet, but we've made a lot of progress. Mary is going to talk later about a new ACS standard that requires all trauma centers, even if you don't take care of kids routinely, to assess pediatric readiness and have a plan to address any deficiencies. The biggest thing that you can do, the most powerful thing, is to get a pediatric emergency care coordinator in your ER. We've put a lot of work in with TQIP and the PEC Workforce Development Collaborative to try to train PECs, we call them, for trauma centers. If you're interested in getting a PEC at your trauma center, please email me or check out the EIIC website. We have all the resources online, they're free. We're happy to help you identify somebody and get them trained up. The second thing we're working on is imaging guidelines. I was part of the writing group that wrote the ACS TQIP best practice guidelines. They're fantastic, but they're way too long. 116 pages is too much to page through when you're resuscitating a child in front of you. There are pediatric sections all throughout this document. But what we're trying to do now is boil each of those sections down, particularly as it relates to advanced imaging, head CT, even whole body CT, abdominal CT, to a 1-page algorithm to follow for people who are not used to imaging children, because the indications for imaging children are a little bit different than they are for adults. So you should look for these to be coming out again. These are all going to be free. They're expected to be released spring of 2023. We're working on improving training for providers. There are a lot of courses, particularly related to trauma and pediatric trauma, but they're not utilized by adult providers. We're trying to identify what those barriers are, trying to tailor courses, and trying to figure out how can we amplify regional pediatric trauma centers into the surrounding level 1s, 2s, and 3s to improve pediatric provider training. And finally, the Emsc Innovation Improvement Center Trauma Domain is working on improving the system for kids. That's why we're here today. I think that we really need to optimize the adult trauma system for children. I don't know that pediatric readiness is enough, but it's a great start. That's what we're working on now. We need to develop a better understanding of how kids move through the system and understanding what happens during the transfer process at the initial center, at the receiving center, so forth and so on. But more importantly, we need better coordination with the regional pediatric centers, because in the context of a disaster or mass casualties, the pediatric centers are going to be overwhelmed. So we need to develop regional networks such that we can work together with our partner adult trauma centers, particularly in rural areas or underserved areas, to provide high quality care for kids. And I would argue that you have to prepare for that during non-stressed times so that when the disaster comes, you are prepared to take care of injured kids. So with that, I'm going to hand it over to Chris Newton, who's going to talk a little bit further about the regional disaster preparedness networks and how we're leveraging these relationships. Thank you.
All right, let me share my screen. And we are, in the interest of time, going to move pretty fast through all of these talks. So thank you, Aaron. I am Chris Newton. I am a pediatric trauma surgeon. I'm the trauma director at UCSF Benioff Children's Hospitals. And several of us are speaking with funded grants that support these programs. Yes, I have federal funding. I do need to make it clear, by no stretch of anyone's imagination should this be taken as me speaking for the federal government. Okay, pediatric disaster, emergency management. There is a particular gap and problem in pediatric disaster management that has been recognized for a long, long time. And kids represent about 25% of the population. And whatever event that you're talking about, very commonly, there's kind of disproportionate impact on kids versus adults. And you can see various numbers of various events listed there. But the resources to take care of those kids are often very concentrated, often in urban centers. And in the US, moving kids, especially moving across state lines or hospitals helping each other across jurisdictions is a challenge. So this problem has been known for many years. There's lots of fantastic groups that have been trying to impact this for a long, long time. And over the past, I would say 2 to 3 years, this has kind of culminated in some really good programs. And this is why we're doing a panel like this. All right. So this is an example of a lot of the programs. You're going to hear about a lot of these. Aaron was just talking about the EIIC and the EMSC. There's lots of different ones. Many of these focus on taking care of kids every day, as Aaron was talking about. Having everyday capability and everyday systems is really foundational to being able to do disasters correctly. So a lot of what we're doing is figuring out how to unify all of these programs into a network or framework that makes sense. All right, so I'm going to talk about the pediatric COEs. So ASPR put out in 2019 a grant for Pediatric Centers of Excellence for disaster management that was regionally based across multiple states. So my group won one of these grants. I'm the Western group. We refer to as RAPM. The other group is the Great Lakes group, which covers Region 5 in the country. Both of our groups are very, very similar. We've worked very closely together. So I'll talk a lot about the Western group, but please note that the Eastern Great Lakes group, or the Great Lakes Region 5 group, is very, very similar. All right, so for me on the West Coast, this all began in 2019. The NOFO came out, very short turnaround time. Everyone around the country, salivated over this massive project and grant. And pulling together all of these, different individuals from academia and agencies was an overwhelming challenge. And getting states to coordinate and work with each other, or at least agree to, was a daunting task. And these projects cover everything. This is boiling the ocean. But we pulled it together. And part of my personal philosophy in figuring out how to get all the groups working together was making sure that the states had some equity in their jurisdictions between each other, and having staff and programs that represented each of those states, and getting rid of ego so that academic centers and agencies, can work productively together on operational things without, getting bogged down in traditional academic, challenges. This is how we structured ourselves. I'm not going to go into detail about all of this, but I want everyone to appreciate the number of different niches. I'm going to try to give examples of a few of these. There's no way we have time to talk about everything that all these programs have been doing. However, if I can give you examples, it'll give you an idea of what kinds of things a regional center works on. And hopefully I can give you some examples of lessons learned and ideas of where we're going over the next year or two. As I said, having equal access and equity has kind of been foundational to a lot of the work that we've done. We intentionally arranged a lot of our products, almost all of them, that are open access. And so everything we produce, we share with our other regional, disaster partners and gets pushed out, to all sorts of places around the country. We began, of course, in 2019, a few months after we initially set up our operations, the COVID pandemic started. And for us, this was a unbelievable learning moment. And the thing that I think we weren't prepared for is transitioning from infrastructure building to actually responding, and responding at a local level and a personal level. And we had to learn how to do this. And I will say this graph represents multiple moments along, the first year of COVID, where we got different requests from different parts of our region for help, or for guidance, or for subject matter expert advice, and how we had to deal with that. Repeatedly, the solutions and the stories were almost always about pulling experts together and offering advice and support, so that people could make decisions locally, the best they could. This is one example of what this ultimately turned into. So about a year into COVID, many places around the country were really struggling with crisis standards of care. And specifically, what does this mean for kids? Because if you talk about crisis standards in pediatrics, it's just a breathtaking ethical problem. So the solution was pulling together town halls and letting individuals from different communities all over the country talk about their solutions and their individual problems. And we began to do this so much that we even did it as crisis standards were de-escalating and coming down. The simple act of sharing was not scientific, and yet profoundly meaningful. All right, mental health has also been a very heartbreaking problem for the past 3 years. It is still a problem. Capacity underlies a lot of this, along with this overwhelming increasing demand because of suicide rates. So our teams pulled together a lot of the best practice solutions from all over the country to create a menu of tools that anyone could use for pediatric mental health. Interesting in this exercise, the realization that paying attention to our healthcare workforce as well was a very important part of the equation. Okay, next project is figuring out about dashboards and IT, bed tracking, bed availability. We do this well sometimes on a local level, but doing it on an interjurisdictional level and across state lines or across counties is really strained. So there's several groups working on this, trying to get better, better sharing and better IT, just to help individual local areas take care of this problem. Okay, mass casualty events. We have a group specifically working on this. I'm not going to go into details, but a lot of the requests were from local community hospitals about how they prepare and gear up their hospital for a mass shooter event. Of course, we've seen too many of these lately. So we pulled together, once again, episodes of sharing experience. So experts from around the country that have actually been at whatever event and talking about specifics of how to take care of kids. This ultimately evolved into a training platform that currently is in process. There is historically a course called the Pediatric Disaster Life Support course. This has been around for 10 or 12 years. University of Massachusetts developed this, and we have taken on kind of revamping this and creating a modular kind of a training exercise that can be used for smaller community hospitals or smaller trauma centers. And that is short and easily accessible and can be practical on a local level rather than taking a grand course that takes 3 to 4 days. We're about halfway through. This product will be ready probably by the end of the summer. All right. The next topic I'll talk briefly about is strike teams. So many entities would love to have a pediatric specific team that only takes care of kids that can deploy. Lots of problems with that, problems maintaining, and problems with ongoing funding. So we took an approach of producing pediatric specific pearls, or just-in-time information, put it into a handbook. The target is adult strike teams that are going to be taking care of kids. They walk into a tent, they see a tent full of kids, anxiety goes through the roof. The hope is that this helps that anxiety just a little bit. We put this out last year, have been putting it out, and it's been just tremendously well received. All right, in the interest of time, I'm not going to go through anything much more. The Pediatric Pandemic Network, Charles is going to talk about. I am the PI for the West Coast, the RAPM group. Charles and I are the co-PIs for the PPN. He will go over that in more detail. The only thing I want to say about that is, in some ways, inspiration. This is just a golden moment and an opportunity to pull together, a unified, national network. And I love this opportunity. The government has finally funded it after many, many years of work getting to this point. And then the final mention, Mary will talk more about the PEDS Ready program. Of course, this is coming to trauma centers in the coming year. And so I'll let her talk about the details. But the inspirational point that I want to put out about this is, don't pass up this opportunity for the PEDS Ready program to be the seed that creates a system and a network and a connection between pediatric centers and adult centers and community centers, and elevates the care kind of everywhere. This is a tool that could do that. All right, I am going to stop and pass this on to Charles, and he can talk about the PPN.
Thank you. It's certainly a pleasure to be able to share more information on the Pediatric Pandemic Network. And really the crux of my discussion is an understanding of how these concepts about pediatric readiness and these concepts about the granular tools that were created within the various networks can be taken to spread. I'm Charles Macias. I'm a pediatric emergency medicine physician and chief quality officer at Rainbow Babies and Children's in Cleveland, Ohio. I serve as the co-principal investigator for the Emsc Innovation Improvement Center, the ASPR Region 5 Pediatric Disaster Center of Excellence, as well as the Pediatric Pandemic Network. You've heard Aaron talk about pediatric readiness, and you've heard Chris talk about the particular issues that make children a vulnerable population. What I really wanted to point out at this juncture is what really became the burning platform for why we now have such a wonderful opportunity to take so many of these concepts in disaster preparedness and disaster response to spread, looking particularly at the needs of children. So as you have heard, children are particularly vulnerable, systems of care not optimized to care for kids. And this concept that if we entirely focus on disaster preparedness, failing to recognize that the antecedents to that the very ability to take care of children every day is what is necessary in order to evolve that care capability to mass casualty incidents, to disasters of broader scale, or to global pandemics. This was really the rationale behind the Pediatric Pandemic Network. We have several lessons learned from readiness and disasters, and we know from the literature that fewer than 50% of hospitals have addressed the surgical and medical needs of children in their disaster plans. And whether we look at school shootings, at bombings, or other mass casualty incidents, the lessons are pretty uniform regarding the gaps in the ability to care for children. So much so that the National Commission on Children and Disasters, in a 2010 report, reported that programs and practices managing disasters are fragmented and unaccountable to children, and the true solutions could only exist with a pervasive concern, a sustained will to act, and a unifying force, something that was finally realized a decade later. If we look specifically to what was able to elevate all of those concepts into action, it was really the pandemic. We Congress was hearing the large increases in volumes for pediatric patients seeking acute care for behavioral health, including increases in suicide ideation and suicide attempts, knowing that there are greater than 160,000 children that experience the loss of a primary caregiver. All of this confounded the effects of the pandemic as they escalated the needs for better care for children. There were gaps in community engagement. Electronic health and a workforce that was gapped in optimization suddenly felt the need and the requirement to manage medical care through telemedicine and pre-procedural assessments, widely variable across the country. There was a disparate access to resources that were exacerbating inequities in care and outcomes of care. Variable how institutions were canceling surgical procedures, variable pre-procedural testing processes, the exacerbation of chronic illnesses confounding all of these delays in care. Layered upon all of this was the great exit from healthcare. Over 1.5 million jobs, really magnifying the needs of improving the staffing and workforce to care for patients across the country, but even more so, specific needs of children. That then exacerbated employee and staff safety and the health and wellness of providers. In response to all of this, Congress then funded, through the Health Resources and Services Administration, a $48 million investment over 5 years in the Pediatric Pandemic Network. Comprised of 5 hubs in a hub and spoke model. It includes Benioff Children's at UCSF San Francisco, Cardinal Glennon Children's Hospital in St. Louis, Primary Children's at University of Utah and Intermountain Healthcare in Salt Lake City, Norton Children's at University of Louisville School of Medicine, and the anchor site, Rainbow Babies and Children's at UH Cleveland. Included in those partnerships are the 2 networks that you've heard about previously, RAPIM in the Region 5 for kids with ASPR, as well as the EMSC Innovation Improvement Center. Now, there is a grand vehicle that allows us both the geography and the expertise to, across the country, truly represent the nuances of what's necessary to improve disaster readiness and indeed pediatric readiness every day for children. With over 27 institutions involved in this phase of the Pediatric Pandemic Network, we touch across 15 states, all regions of the country. Our mission really to leverage children's hospitals, not work within children's hospitals, but to leverage children's hospitals to empower all healthcare systems and the communities in which they reside to provide high quality, equitable care. And that's really critical to the PPN's vision for what children and families should be receiving. Our goals are layered at 4 levels: to increase the number of collaborations and partnerships of children's hospitals with systems of preparedness so that they can then leverage those relationships with communities, community hospitals, faith-based organizations, and really anyone who would be touched within the continuum of care. To improve pediatric readiness across health systems as influenced by children's hospitals with their expertise, but not being delivered at children's hospitals. To increase the capacity and capability of telehealth. And then finally, to accelerate the real-time dissemination and uptake of evidence-based or research-informed pediatric care. All of this operates within 4 categories of pediatric readiness. We call them domains, but you can think of them as national task forces with some of the leading experts across the country and some actually in Canada as well. Those domains fall into the categories of access to care, inclusive of telehealth, everyday readiness, inclusive of a domain for trauma, burns, and mass casualty incidents, a category of pediatric readiness and disaster preparedness, including deployable assets, as you heard about previously, and finally, at a very foundational level, the improvement of improvement science integration into the way that healthcare infrastructures deliver care to kids, and that can include drills and exercises. We operate within the entire continuum of the emergency medical services for children continuum. That includes pre-hospital care, that includes hospital-based and primary care-based care delivery, as well as preparation and prevention through research, education and training, and response planning. Our everyday readiness supports disaster readiness from the very foundational elements that you heard about, that we can't be ready to care for kids in a disaster if we can't take care of them every day. And some of the national pediatric readiness projects that you heard about previously really represent assessments that have been conducted for the last 20 plus years on about a 9 to 11, sometimes 13-year basis, with the last assessment that was completely analyzed in 2013. The most recent assessment last year is currently under analysis. What we have learned is that higher pediatric readiness scores correlate to improved mortality for critically ill children, with those hospitals or institutions scoring in the highest quartile having almost a quarter of the odds of death. And that's true whether that is medical disease or whether that's trauma, with that data illustrated on the right showing adjusted mortality decreasing as pediatric readiness scores for trauma increase. So the structural investments that you've heard that most affect pediatric readiness and then become our vehicle for dissemination are pediatric emergency care coordinators, the PECs you heard about recently, but also inclusive of facility recognitions, codifying the way that we acknowledge or recognize structures for pediatric readiness in emergency care settings, similar to verification programs for surgery. Our everyday readiness supports disaster preparedness through those 6 domains of quality that you heard Aaron talk about earlier. But we are making progress in expanding that. We are taking the periodic National Pediatric Readiness Project survey into continuous measurement so that we measure the quality of care and pediatric readiness across the nation's over 4,000 emergency departments on a more continuous basis. And we are also currently in the throes of expanding our strategies and launching the pre-hospital pediatric readiness project that will then take the same concept into pre-hospital systems, into agencies, over 17,000 of them across the country. And I illustrated there on the right, standards for verification that Mary Fallat will talk about more. My point in that slide is really to make the point that we can codify this process. And by codifying the process and providing the tools, we can really make a difference through quality improvement. And that, in fact, is the foundation of the work that we do. With analytics and a rapid data access, we're creating national platforms to drive quality improvement collaboratives, which are all teach, all learn collaboratives that allow institutions and healthcare systems the ability to participate in pediatric readiness through collaborative analytics, through QI methodologies, and through evidence-based practice with quality improvement strategies. We support teams to help enhance their capabilities, and we educate across systems with automated just-in-time tools, as you see illustrated there to the right. Our quality improvement collaboratives are increasing in number and in number of participants. The Pediatric Workforce Collaborative that has grown the number of PECs, when it launched, had 1,500 participants seeking to become PECs across the country, which is just a profound number and a profound amount of interest in really growing the people who would champion this work. So our roadmap to success, where we're headed, producing new training materials and exercises, integrating EMS and pre-hospital systems into the pediatric disaster response, creating a national pediatric disaster research agenda, which currently doesn't exist, incorporating telehealth into state, regional, and disaster planning, developing a national surgical emergency management surge template, creating models for pediatric coordinating centers to build capacity and to go across state lines, and the most recent news, a congressional expansion of the Pediatric Pandemic Network with now an additional almost $40 million investment to expand the PPN to 5 additional hub sites. So we're delighted with the direction this is headed. What can you do? Strengthen your communities, join our collaboratives, engage your institutions in our drills and exercise, identify and support PECs, and access and disseminate our tools. And with that, I'll turn it over to Mary.
All right. Hello, everybody. I'm delighted to be a part of this network, and I'm going to talk to you a little bit about the global aspects of this and importance for us as surgeons. The acknowledgement is the same. Why should you care about this is one of my areas of messaging. So if you look at rural America, in 2017, there were 326 million people in this country. Rural Americans reside in 80% of the total US land area, but only comprise about 20% of the population. And nearly a quarter of those individuals are children, less than 18. About 16% of these children live in poverty, and 26% of households in rural America have no internet access. So when I am trying to do a telehealth visit with some of my patients who live in rural Kentucky, it's really just a phone call because they aren't able to get on Zoom. On this map at the right, you see what rural America looks like. It's a snapshot. And 7 out of 10 states have a larger percentage of rural population than the national average. Anything that's green is more than 50% rural, the darkest green being primarily a rural state. On the left side is the poverty that you see in this country. If you are shaded dark purple, then the majority of the kids in that community are living in poverty. And it's an urban community, and darker green represents a rural community. So much of the country lives in poverty. I know this is a favorite show for many young people, but what does it really mean? In 1970, Nixon launched the war on drugs, and soon after, many of the individuals who were opioid addicts or selling opioids were incarcerated. And on the right, you can see that there was a rapid increase in the number of individuals who are in state prisons, local jails, and federal prisons. Many of these were the parents of our patients. And so we see many of the kids come to the office in the company of their grandparents or foster care because one of their parents is dead, one of them is in jail. Not an unusual story. In addition, a few weeks ago, we all heard that 1/3 of Black and 1/6 of Latino boys are destined to go to prison sometime during their life. And so the mental health disparities that you heard about from Dr. Macias are real. The other thing I wanted to just bring up is the climate change that we're seeing. There's a great documentary by Richard Attenborough that notes the 9 planetary boundaries beyond which we can't push Earth systems, and that for at least 4 of these, we have already surpassed the safe operating space. And those include climate change, biodiversity, land system changes, and biogeochemical flows. And what that translates to is what you see on the borders of the COVID virus and the pandemic that we've just been through. So deforestation has resulted in flooding of places that didn't used to flood, mainly in the southeastern United States. Kentucky just had a big tornado. Forest fires are ravaging the western part of our country, in addition, are now reaching Europe. We always have a hurricane season that's sometimes worse than others. So let's talk a little bit about access to trauma care. There are about 6,000 hospitals in the United States. 5,000 plus are considered acute care hospitals or community hospitals. That includes non-federal hospitals. It includes academic medical centers. It includes small trauma centers, critical access hospitals. And of those 5,000 hospitals, nearly 2,000 are rural community hospitals. When you put that in perspective on this map, you see the regional hospitals on the upper left. On the right are the level 1 and 2 pediatric trauma centers. Bottom right are the level 1 and 2 adult trauma centers. And on the left are the verified burn centers. And there's a great gap in the plains of this country and some parts of the West where there is not sophisticated care to take care of kids. This is a map of level 3 and 4 trauma centers on the left. There aren't many pediatric level 3 trauma centers. Compared with the regional map, you can see that there is a lot of opportunity there to take better care of kids in these regional environments. Critical access hospitals account for some of these hospitals. They are not always trauma centers, but they can be level 3 and 4 trauma centers. And they're often a vital part of the local economy for a county. Many of them are in monetary trouble, but many are also ill-equipped to take care of children who are seriously ill or injured. Just to put that into perspective, more than 80% of children are seen in general emergency departments, and about 70% of the emergency departments in this country see less than 15 pediatric patients a day. With those low volumes, it's difficult to establish pediatric quality metrics and performance standards at an individual site. So you've heard about the National Pediatric Readiness Project. The idea and the program started in about 2001. It's gone through several iterations. And I think the awareness that it's important not only to children who have medical problems, but also children who have surgical problems has now come to the forefront. And as a pediatric surgeon, I can tell you that 40% of what I do is emergencies. It's trauma, it's burns, it's appendicitis, belly pain, midgut volvulus, and tussoception. For those of you who are acute care surgeons, these are real world problems, and many of them walk into the doors of the smaller emergency departments. I'm not going to dwell on this again, but rather to talk about this pediatric emergency care coordinator that is probably at the core of the pediatric readiness program. But this person cannot exist in isolation. It's a team effort. One is good, two is better. So if there's a nurse and a doctor who both step up to the plate, that's really tremendous. And they rise to take charge of the pediatric QI, of making sure the equipment's working, people know how to use it, that if a sick child comes in, they have the right drugs, the right doses, the right tubes, and the right connections to an upper level of care and how to get the patient there. So it's an entire checklist, and administrative sign-on is really essential. And so for the first time in the verification process in August of next year, it will be a requirement that a trauma center be pediatric ready. So what does that look like? It means that for every level of trauma center, the emergency department must evaluate its pediatric readiness and have a plan to address any deficiencies. You've heard many times during this afternoon what pediatric readiness is, so I'm not going to repeat that. But the measure of compliance will be a gap analysis with a plan to address deficiencies in pediatric readiness. It will be a type 2 criterion deficiency. And as most of you know, a type 1 is a dead stop, but a type 2, there can be up to 3 of these. In these center can be verified still for a year, as long as they correct those deficiencies within 12 months. But if any type 1 deficiency or more than 3 type 2 deficiencies are present at the time of the verification site visit, the hospital will not be verified. There will be several resources. Since the book is somewhat on a virtual platform, there will be the ability to modify these and update them. And I add this slide because there are intuitive ways that a trauma center can start to prepare for this change. There's a whole website that's devoted to pediatric readiness. There's the ability to do the survey and compare your emergency department to the state average. This state average is not only housed online, it's also available with resources from your emergency medical services for children program manager in the state. And if any of you need access to that person, any of us on this call can help you find them. You can do a gap analysis, look through the toolbox that's present, and appoint a nurse and medical, an MD, PECCs or Pediatric Emergency Coordinators to be your key people in the emergency department, and begin to address the gaps and describe how they're doing in the PRQ. But I also add this, the surgeons on the call are not really the engagement that is going to take charge of this program. It's really the front line in the emergency department. And so a team effort is really important. It's important for your trauma program manager to get to know the individuals in the emergency department and who they are and how they're approaching this. And then for the trauma team to understand what the gaps are, and together to try to help to start to look at those gaps. The domain here for trauma and burns, which is part of our hub, our long-term goals are to promote the development of individual state infrastructure to support pediatric trauma system planning. We're starting to align with the American Burn Association just to look at those gaps across the country in burn care and recognize what other sites are available to take care of kids with burns, to facilitate the development of standards for pediatric trauma recognition. So not necessarily to verify you as a pediatric trauma center, but to recognize you as one that's capable of at least stabilizing pediatric trauma patients, working them up well, and transferring them if you're not going to admit them. And I think children really need to be integrated into the National Trauma System Plan and the RMOCs that are starting to be promulgated across the country, so that we're working together with you so that, again, it's a team effort. And so the take-home points are that children enter emergency departments all over the state, region, country that are currently ill-equipped to care for their emergencies. The HRSA network that you've heard about today funds programs that emphasize emergency care for children and is a good partner for surgeons. And a state trauma system that is inclusive of pediatric needs can work well in an emergency and is a scaffold for other emergency planning. We know that historically, but it has to be pediatric ready. So I think our charge is engagement. It's a system team effort to partner with the HRSA programs and to remember that bi-directional communication and education to extend our outreach, not only to trauma centers, but rural and underserved hospitals is really important in embracing pediatric readiness as a first step to raise all boats. Thank you for your time today.
Mary, thank you very much. I want to thank all the presenters. This was really a very concise, very broad, at the same time, presentation on a very important topic. So I have a couple of questions. I was hoping, as the moderator, my job is to help feed some questions to the group. So I guess the first one, looking at kind of bureaucratic processes in general, and I think this is a really difficult job for you all as you advance this concept. Like if your hospital is paying somebody to be in charge of pediatric readiness, their job is pretty much to tell you, yeah, we're ready, right? I mean, that's the job, right? So how do you get an accurate assessment of where you stand? Because I think all of us intrinsically know that there's a gap between what you maybe say on a form when you're returning it and what's really in place. So how do you, in a non-judgmental kind of way, like Mary just said, you're trying to raise all boats, how do you apply the culture or change the culture such that people, look at this in exactly the way you just presented it and not check the box, always say yes, move on?
That's a great question. I can tell you what we're doing in Kentucky. We have a pediatric readiness recognition program for hospitals, and we received some additional funding, and we do site visits, and we have developed a course to teach people how to do site visits. And you go into the emergency department, and it's just like a trauma verification visit. We go in and do a site visit. We spot check the equipment, the protocols, We talk to the staff, we look in the cabinets, and then look to see if there's a Broslow card or something that would enable them to resuscitate children. And we hear about their projects. And so it's just like a trauma site visit.
Yeah.
And I would add that there are currently only 17 states that have facility recognition programs in the final stages of development or completely or completed. We still have a ways to go, but that absolutely is a way to empower effective implementation of pediatric readiness.
Good. So I have a question from the group, from Dr. Cools in Nevada. Are there pediatric emergency tabletop or other exercises that small hospitals can use to practice readiness?
Yeah, there's several templates that the different COEs have been working on over the past couple of years, and those are available. We make them available to everybody, and there's good examples as well of how to run a drill like this while you're syncing with other hospitals, not just an isolated community hospital. Because if you do it just in your backyard, you're only drilling half the problem. And so some of the tabletops, you should partner with your mentor, and your mentor may be Mary, who just did your site visit and came out and helped your PEC fill out your checklist. And then your mentor hospital and your community hospital can do one of these templates together, and your system just got better.
Good. Let me ask you, your group, another question. So on one of the slides, it was a bullet point, but it really wasn't discussed in great detail. But when you talk about pediatric readiness at the hospital, especially in a rural environment, the EMS piece is really important, right? So how comfortable are your EMS providers? You know, do they know the basic things to do? If there's a choice, do they go to the right place? Many times there's not a choice and they go to the only place they can go. But I saw that EMS is part of it, but you guys didn't highlight that maybe as much as I would consider highlighting that as you go forward, because that's really the first entry for injured kids many times into the system.
No, that's an excellent point, and a couple of my slides made reference to it. And in particular, I think thinking of this within a Donovan structure of how do we go from structure to process to improving outcomes within a natural flow of quality improvement. We are putting the structures in place for pediatric readiness at pre-hospital systems. We have a national partnership with several representatives of several organizations that are about to launch a pediatric readiness assessment for pre-hospital systems. Our goal ultimately is to empower that team and that effort in the nation's over 17,000 agencies.
And the last question I have, looking at the clock, I think we have time for one more. You mentioned, once again, a single bullet point on the rural trauma team development course. That is such an impactful way of reaching rural hospitals. And I think, you know, it's easy to overwhelm them with trauma care. Like, you come down there for a day and really kind of power stuff through. But I really appreciate and admire the fact that you guys look like you're going to bolster a little bit of the pediatric section, because maybe there's some stuff we're teaching that maybe is not quite as important, but the pediatric part really is important. And, you know, some basic trauma principles which apply to everybody, but then where are kids different, and why you shouldn't maybe be scared of kids, because you are the only place that's going to care for this kid, you know, like somebody said, we're 9 hours south and 5 hours north, or whatever it was. You know, so I think, you know, rural trauma and other courses like that speak not to the level 1 pediatric trauma center, but basically to every other hospital that's really saddled with this problem. So I think that's actually really very important. And I thank you guys for considering all that.
Yep. Yeah, I agree. And Mark, I'll say there's a lot of really good training efforts going on. The Rural Trauma Surgeon Program is one of those. You know, we have a pediatric disaster life support course that we're evolving, just ATLS. There's lots of different things that you can do to help elevate the capability. But as Aaron's case pointed out, you need to elevate that capability to take care of a child on a random Tuesday. And that's where you begin. and that includes your EMS infrastructure, and you make that better. And then we can talk about the moment when, you know, you have 60 kids. God forbid.
Very good.
Just a
Well,
shameless plea for those on the audience today. You will be receiving a survey from TQIP that is trying to understand what you as adult trauma surgeons need for pediatric training. What are the barriers? How do we need to deliver this course? What content? We want to know how to make pediatric trauma provider training likely within a course, probably as an add-on to RTTDC, but we want to make that accessible to everybody. So please make your comments freely available to us in the survey. We would really appreciate it. Thank you.
So in the chat, if you have more questions after this webinar, you can continue the discussion about the topic we just talked about on the AAST Connect. There's a link in the chat you can click, and that way you can continue to ask questions and have this issue discussed. I want to thank all the presenters. This was really a fantastic topic. I want to thank all the people who joined us today, for attending the grand rounds. I'd like to remind all the participants that you should turn in your AAST sign-in sheets to the office for credit before Friday, July 22nd. I would also invite you all to join AAST grand rounds on Wednesday, August 17th, which is the next session. The topic will be healthcare economics. So it's truly a great, really a great session. I appreciate very much the group coming together to do this. It's a logistical challenge to get the quality speakers, all who are experts in this topic, all in the same place at the same time. And I really appreciate the energy that people put into making sure this could happen. So with that, looking at the clock, I think we're right on schedule. I appreciate everybody helping me do this right on schedule, and have a great night. Thanks, guys.